Well, PTSD, as it's commonly known, is really the arrested recovery, the delayed recovery from traumatic events, which are generally, extremely frightening or distressing things that might have happened to us, whether it be a car accident, being assaulted, being in a war zone, being a paramedic, or being in a natural disaster. We all have the capacity to recover from those events, but on average, about 20% of people will have a delayed recovery. And of those, a certain number, maybe 5%, will go on and develop what's called PTSD, post-traumatic stress disorder. Well, firstly, if they're deployed on operations, they're going to be experiencing an awful lot of traumatic events, and some of those are going to be of a pretty, difficult, gruesome, and chronic nature. If someone's involved in events day after day after day, they're more likely to suffer from PTSD. We kind of know that. And veterans are a unique population in that historically, particularly World War II veterans, you'd come back from war and you'd kind of keep stum and you wouldn't talk about it, you'd suffer in silence. But obviously the culture is now changing, people are talking about trauma more. But there's still a sense of kind of not asking for help and stigma about appearing weak. I think, there's a possibility that as conditions become more entrenched over the years and people learn to respond to them in certain ways and maybe close their mind to the possibility that it's treatable, that perhaps that does make it harder to treat. And then you mix in alcohol and other coping strategies. And younger veterans may be a little bit more have a different perspective and a different perception. I've treated young and old veterans, so both are treatable, but I think you may be right that older veterans with longer entrenched PTSD is harder. Well, again, it's, someone will only come forward generally very often when life crises get in the way. So people will just learn to endure what they're experiencing. And unless the wheels have completely fallen off and their marriage is broken down and they've lost their job and they're experiencing a much more severe nature, people tend to endure it. So I think it's a whole mixture of issues, from the availability of treatment, knowing that a person knowing that it's there, and having the willingness to go forward. One thing that is clear from the research, actually, it's partners or wives or family that push people for treatment. That they play a major role in helping veterans, especially, come forward for treatment. Well, it's not so much that. I mean, there's a lot of debate around alcoholism, which is obviously prevalent with veterans, and treatment of PTSD, which very often is the root cause of the alcoholism. They're using alcohol as a way of avoiding the PTSD and all of the symptoms of flashbacks and nightmares and everything else that go with it. So it's actually quite difficult to treat someone for all of that stuff. Some treatment services, some NHS services, require you to be dry for a period of months, and that may be very challenging, and that will put people off. If we're talking about third sector organisations, they just won't have the resources to deal with that kind of complex situation where you've got PTSD that's pretty active and difficult to an alcohol rolled in. To put this in perspective, I've come across veterans who will be digging trenches in their garden to take cover in, and it's a common question for someone with PTSD is, does it feel like it happened yesterday, the traumatic event? And one guy said to me, he said, no, it feels like it's happening right now. And that's the insidious nature of this. So something that might have happened 30 years ago in their head is happening right now with the same intensity, causing them to do all sorts of strange stuff. We heard the car backfires and a veteran dives to the ground. It's a pretty difficult thing to cope with. This is not straightforward and easy, and it's not something you can man up to and just get over. It's, Well, I think, so one of the issues with veterans is generally they have worse outcomes with PTSD treatment, and generally they're harder to engage. So and one of the reasons they're harder to engage is because they come from a particular culture. And so, of course, someone that comes from the same culture will be able to empathize and understand the language and the experience in a way that makes them more able to open up. So it is very helpful, if you're treating a veteran, to be a veteran yourself. Having said that, I know several therapists who aren't veterans, but they understand the culture and they can empathize and they can do a job perfectly well. So it doesn't have to always be that way, but I think to really engage veterans in treatment, you need to understand where they're coming from and understand about their experience. The empathy side should always be there. The question is, some veterans, you know, they've endured it for so long, they do want the respite, they do want to just talk about it. But on the other side, the kind of society and the medical research people, they're always looking for the silver bullet that will treat things, and generally that comes in tablet form. And MDMA, ecstasy, as they're doing trials at the moment to see, you know, because that can be used as a potential treatment. The danger, and there are dangers with both ends, and probably again all of these things come down to pragmatic views, where there are effective treatments that you know, we don't need to keep looking for the one treatment. You know, it always hits the news, you know, new treatment for PTSD. We've already got some great treatments that are incredible, that can, you know, some people would say work miracles, but kind of we're always looking for the next thing. So you've got that on one end, and then you've got people who kind of want the respite care but don't really want to engage in treatment, but maybe they don't really know what the treatment involves. So again, you need there is a pragmatic view, and a lot of those people in respite care could certainly be helped by treatment done by sympathetic therapists. Even thinking about the word cure is probably the wrong question. So I would like to say, you know, if someone cut their arm, you're not looking for a cure, you're looking for a treatment. You want to stabilize the wound, you want to clean it, you want to create the conditions for healing, and then you want it to heal up. And that's the same with PTSD treatment. We've got the good treatments. You know, there's always tweaks and improvements, but we're not looking for the silver bullet anymore. We've got an armory of different things that you use in different circumstances, and yeah, there may be a scar left, but at least it's not a gaping wound that's infected. That's an often kind of voiced opinion. You know, what should the government do? More money, they've deserted our veterans, there are no services, it's all a disaster. And of course the truth is that's not the case. We've got veteran-specific NHS services that are staffed up by people I know who do really good work. I don't believe they're overwhelmed with demand, and the issue is much more complicated. So within the media, there's a zeitgeist that there is no that PTSD is a massive problem and there's no solution, and that the government's not doing anything, and there's belief in veterans that it's untreatable, and then you've got everyone's got different views. I think what needs to happen is people need to change the narrative to, well, who's doing the best treatment? Which NHS services are doing well? Which NHS services are overstretched and need more resources? So again, every issue that we've talked about within this interview, it's a more complicated, nuanced answer, and it doesn't require these big, you know, just throw more money at it, or just do this, or just do that. It's more nuanced, but you know, we've got the solutions. We just need to get them out there in the right place and in the right shape and the right form and everything else. Well, the first thing is very often the partners, wives or families that push people for treatment. Not an uncommon thing that I've heard in my treatment room, where the guy, and it's not always men, it can be women, will say, you know, my wife's going to leave me unless I get treatment. So kind of, you know, then you've got some motivation. One of the skills of a trauma therapist is not to open stuff up and not to get people to talk about stuff until they're ready and until it's right. And again, come back to the earlier questions of, you know, maybe people having poor therapy. There are plenty of examples of veterans getting poor therapy from poor therapists who keep getting them to relive the experience and tell them all about it, and it's just not helpful. So I've got a chap, in fact I'm working, doing some pro bono work with a therapist in the NHS who's got a veteran who doesn't want to talk about anything, and he's evidently having a lot of problems. And you don't need to talk about it. You can do some very effective treatments to sort out nightmares, to reduce the overall levels of trauma without talking about it, using the most innovative and up-to-date psychological approaches, which are there. You know, we don't need them. You know that, and if I describe them to you and describe the kind of results you can get, you would probably be blown away by it. But they're there. They don't work for everybody, but there's some very, very good treatments there. Well, it's again interesting one. You know, the politician's view would be every suicide is a tragedy. The official information from the King Centre of Military Mental Health Research is that the rate of suicide within veterans is no greater than the civilian population. The only area where it slightly increases with younger and the younger service leavers, and they've identified a particular category of people which are called early service leavers. So these are people that leave before their end of service, if you like, so within the first couple of years of joining, who may have had issues before they joined anyway, because the military tend to recruit people who may have issues or disruptive, difficult childhoods, for example. It's a well-known thing. So, you know, one could say that the rate of suicide is no worse, so we shouldn't be concerned. On a pragmatic view, I would say, you know, one of the reasons why people commit suicide from PTSD is because they've lost complete hope. The symptoms are awful. You know, I've come across people drinking a bottle of whiskey a night because they have the nightmares that they know are coming, or they won't go to sleep because of the nightmares that are coming. And we've got treatments that can be used very quickly. You know, if I see someone for an hour, I can teach them how to stop their own nightmares. All of those things would go to reduce the risk. So, you know, it's a big hill to climb. But as I said, it's all of that stuff is treatable. But it's not, the media says there's a tsunami of, you know, PTSD cases coming forward and that all military people are damaged from combat. And that's also another, you know, mistruth. The majority of people with military experience do very well when they transition and leave, with lots of skills and lots of life experience. And, you know, the case that every veteran is a broken and whatever damaged person is also not true. So the first thing I want to do is to normalise the experience of whatever they've had without even talking about it, educate them about trauma and give them hope that it's treatable. I worked with someone the other day who's been in a car crash, relatively minor accident, but their lifestyle has changed quite significantly. And just giving hope that it's treatable and say, yeah, I've dealt with this before, we can do this and understand it, has a massive impact. And I would do exactly the same thing. If they were reporting symptoms of nightmares, I'd be treating that in the first session. You know, it's not uncommon. I worked with an Iraqi war veteran a number of years ago, I think 6 sessions, and he went from, you know, his wife wanting to chuck him out and to pretty much full recovery, getting a job and cracking on with life. It's possible, and it doesn't have to be years of treatment. The best way of explaining it is to describe a story about Simon Weston, who most people are familiar with, was a Welsh guardsman terribly burnt in the Sir Galahad bombing in the Falklands War. He came back and they made a documentary, and he's kind of a well-known chap. But I heard an interview that Jeremy Vine did with him, and he described how his PTSD left him. And right at the beginning I said that PTSD is basically just it's the delayed recovery from a traumatic event. And what Simon Weston described was how he naturally recovered from PTSD 24 years after the event. So he was describing how he had these terrible nightmares of waking up literally every night for 24 years on board the burning ship where all his friends were burning, and he'd obviously wake up with terrible night sweats. And then he said 24 years after the event, on one night, for no reason in particular, he woke up in the morning and it felt like a band had been taken off his chest and his PTSD had gone. It was that dramatic. And he said that night he remembered dreaming, and instead of dreaming about the guys burning on the ship, it was as if nothing had happened and they just marched off the ship and they were all digging their trenches on the Falkland Islands and having a laugh. The most bizarre thing. And it was very light and bright. And that was a spontaneous change of his dream. And that in a way is what PTSD treatment is about trying to do artificially. So Simon Weston had a natural recovery from PTSD, and a very dramatic one. We try and get the same recovery, we try and engender the same kind of thing artificially. One of the ways we do that is through the use of rapid eye movements in a form of therapy called EMDR, which stands for eye movement desensitization and reprocessing. Bit of a mouthful, but it's a World Health Organization NICE recommended treatment. And the idea is that these eye movements are a little bit like rapid eye movement sleep, in that they foster the adaptive processing of traumatic information in the mind. And that kind of approach can work really quickly, where an event that was previously disturbing in maybe one session, sometimes within 5 minutes, can sometimes no longer appear disturbing, or it appears distant, or they can't even remember it anymore. And that's when I said earlier about the kind of the miraculous, some people, that's actually quite miraculous that something's been stuck in your head for 24 years and then suddenly is no longer a problem. Historically, treatment for PTSD and trauma would involve someone reliving and retelling the experience multiple times, hundreds of times sometimes. And of course, that is quite hard going on the person. And that's possibly why combat veterans have experienced worse outcomes with treatment, because those old treatments, you really had to endure it. Some of the newer stuff, like the eye movement treatment, EMDR, they're still hard to endure, but they can get there quicker. So I've seen people where 2 or 3 sessions of EMDR would achieve what 15 sessions of what we call exposure therapy would have done. So if a new person was coming through the door, a new veteran, and I was treating them today, we wouldn't be starting with the eye movement stuff in session 1. That can kind of accelerate the process. So all good trauma therapists should be able to apply brakes and accelerators. And that's about keeping the person within what we call the window of tolerance, so that they don't get overwhelmed by their experience. An inexperienced counsellor or therapist would kind of say, well, tell me about the burning ship on the Falklands. And that will just, that can just cause what we call an abreaction. So literally they re-experience the whole thing. People will talk about running out of the room, that's it, I'm never coming back. So a good therapist can apply brakes and accelerators and use the most effective techniques. But actually that can be the really hardest thing. So I've worked with a young guy, he was 20, he was sexually abused at boarding school. He doesn't want to tell you about some guy, awful. So actually there's some what we call blind to therapist treatment. So I treated that without him having to recount any of that stuff. And likewise with combat veterans, you don't want to tell them about the bits of their friends that they picked up off the ground. I mean, so that's why you need, in terms of when you go back to the question of what does the government need to do, you need to have well-trained and well-qualified therapists who can work with military people, veterans, and to an extent that's kind of we've got regional NHS services, and they're not bad. I know the people that work there, they're good therapists using the stuff that I'm talking about. So I think where one of the other issues is there are a lot of people trying to help veterans, and you may get misguided, poorly experienced therapists trying to do work that actually, gives them a bad experience. And then if you've had one bad experience, it's like, a customer in a restaurant. You go and tell 10 of your mates, that was rubbish, I'm not ever doing EMDR again. So it's a complicated thing. But it's like the old, is it the starfish on the beach? You throw one back at a time, and the next person you see, you do the best job you can, and in the main you get good outcomes. That's my experience anyway. Great question, because I've had a kind of a checkered career. So I left school and joined the military, then went to university as a sponsored student, and then I didn't get back into the military because of hearing loss and some episodes of depression at university, ironically. I then worked in manufacturing engineering and management consultancy, so I had a whole different career until I was about 40, 41, 42, and then I went back to university and retrained in therapy and counselling. Tooled myself up with the best, what I consider to be the best approaches for treating trauma. And because I've got an interest and a history with military, I wanted to kind of work in that area. I do work with other people, obviously, but that was the motivation. So I've had a kind of rounded career, and then I also have a research interest, and I'm finishing a PhD. So that's all to do with traumatic nightmares in veterans. So it's kind of full circle coming around, really, which is quite ironic. It sounds slightly grandiose, but I'm going to say it anyway, which is the global eradication of nightmares by 2030. This is something I believe is possible without, smallpox has been eradicated through massive global vaccination programs. Nightmares could be done so, but with much cheaper technology spread on mobile phones. It's perfectly possible. There we go.
Thank you very much, Justin.
That's all right.
That was awesome.